Every day in operating rooms across this country, surgeons are patching up people who should never have ended up on that table. A small plaque, barely visible on a scan, grew silently for years. And then one day, it ruptured, and everything changed in seconds. Cardiovascular disease is the #1 cause of death in every single developed nation on Earth. Not cancer, not accidents, your blood vessels are what kills you most. And most people have absolutely no idea what is happening inside their own arteries right now. They're not going to tell you this at your next appointment. The system makes money when you stay sick, not when you stay well. Subscribe and hit like if you want the real story. Help Dr. Waterling reach 100,000 subscribers. Let's start with what matters most. 3 symptoms that mean you go to a doctor today. Not tomorrow, not at the end of the week, today. The first symptom, you're climbing stairs to the 2nd or 3rd floor. Maybe you're shoveling snow. And suddenly, during that physical effort, you feel a burning or a squeezing sensation in your chest. You stop, you rest for a minute, and it goes away. You probably told yourself it was fatigue, maybe anxiety. It isn't. That is classic exertional angina. In plain terms, chest pain that comes on with effort and eases with rest. This is how coronary artery disease shows up. The coronary arteries are the blood vessels that feed the heart muscle itself. When those arteries are narrowed by plaque, your resting heart gets just enough blood to function, but when you push yourself physically, the heart demands more blood than the narrowed artery can deliver. The result is pain. That pain is your heart telling you it is in trouble. You need a cardiologist immediately. The second symptom is trickier because it doesn't announce itself as loudly. This is cerebral ischemia, reduced blood flow to the brain. You might notice you're thinking a little slower than usual. Things that used to come easily now take more effort. But the truly dangerous episodes are what doctors call transient ischemic attacks, a TIA. That means a temporary ischemic attack. One arm suddenly feels weak, or one side of your face droops slightly, or words come out garbled when you try to speak. It lasts a few minutes and then it's gone. And that "it's gone" part is exactly why people ignore it. Must have been nothing, it passed on its own. No, a TIA is the warning shot before a full ischemic stroke. It is your brain telling you that a vessel is critically narrowed and the next event may not be temporary. You need an ultrasound of the neck arteries or a CT angiography. That's a specialized scan that uses contrast dye injected into your bloodstream to show the inside of your arteries in detail, and you need it now. The third symptom is atherosclerosis of the leg arteries, and it shows up as something called intermittent claudication. Claudication is the medical term for a very specific pattern. You walk 200 to 300 meters, sometimes as far as 500 meters, and your calves start to burn and cramp, like you've just pushed through a brutal workout. You stop and rest, the burning fades, and you walk again. People chalk this up to being out of shape. It's not. This is ischemia of the legs, insufficient blood supply because the arteries are narrowed. You need a vascular surgeon and an ultrasound of the leg arteries. And here is the statistic that should stop you cold. Most people are afraid of heart attacks and strokes, but almost nobody knows that in severe leg ischemia, when it progresses to gangrene and amputation, the 5-year survival rate is only 10%. 10%. That means 9 out of 10 people with an amputated limb die within 5 years. Not from the surgery itself, but because they cannot psychologically or physically adapt to life after amputation and they deteriorate rapidly. That is not a scare tactic. That is documented statistics. So those 3 symptoms, chest pain with exertion, episodes of arm weakness or facial drooping or speech problems, burning in the calves when walking, each one is an emergency. Don't panic, but act. Now let's go deeper, because understanding what atherosclerosis actually is will change how you think about your own body. And here's the first thing I want you to really hear. Atherosclerosis is universal. Every single person who lives long enough will develop it. This is not an exaggeration. I have spoken with pathologists, doctors who perform autopsies, and not one of them has ever examined a person over 60 years old whose aorta showed no signs of atherosclerosis. Not one. When a pathologist opens an aorta, that's the largest artery in the body, the main highway that carries blood out of the heart. They run a blade along the inside wall to clear the blood away. In a young person, that inner wall is white and smooth. In a person over 60, it is covered with yellow deposits. Those are atherosclerotic plaques. And when the pathologist cuts through the aorta, you can actually hear a crunch. That is calcium. Calcium that has hardened inside the plaque over years and decades. Calcification tells you the plaque has been there a long time. If the plaque surface is intact, that's relatively safer. But when a plaque ruptures, that is when the catastrophe begins. If you've had an artery ultrasound and someone found a plaque, I want you to understand something right now. That is not an automatic death sentence. I've seen patients spiral into panic, calling every surgeon they can find, demanding that someone cut out a plaque that blocks 30% of the vessel's diameter. That surgery is not indicated. What you need is to understand why that plaque formed and what to do about it going forward. Across 15 years of clinical practice, I've seen thousands of patients with vascular problems, and the pattern in the data is stark. Approximately 40% of patients with severe atherosclerosis are smokers. Another 40% are diabetics. That accounts for 80% of serious cases. The remaining 20%, everything else combined. Two enemies dominate: tobacco and blood sugar. Why does smoking destroy arteries? The toxins and tar from cigarette smoke enter the bloodstream, and day after day and year after year, they physically injure the inner lining of blood vessel walls. That inner lining, the endothelium, is not a passive pipe. It's living tissue that reacts to damage. And here is where one of the biggest myths in popular health culture falls apart. Cholesterol is not the villain. When the vessel wall is injured, cholesterol is dispatched to the site like a repair crew. It fills in the damaged areas, sealing the wound. Cholesterol is doing its job. The real enemy is whatever is causing the damage in the first place. Stop the damage and the cholesterol stops piling up. Why does diabetes attack the vessels? In type 2 diabetes and in poorly controlled type 1, blood glucose is chronically elevated. Proteins in the blood, the cells that line vessel walls, the connective tissue surrounding the arteries, everything becomes glycated, meaning sugar molecules bond to these structures and deform them. Instead of normal flowing blood, the circulatory system is carrying something closer to a slow, thick syrup. The vessel walls become stiff and damaged from the inside out, making them the perfect breeding ground for plaque formation. The hormonal system plays a significant role here that most people do not know about. Before menopause, women are substantially protected from atherosclerosis. Estrogen, the primary female sex hormone, acts as a biological shield for the vessel wall, maintaining elasticity and reducing inflammation. When a woman enters menopause, that shield disappears and atherosclerosis begins to accelerate in women at the same rate it does in men. Men, for their part, go through their own hormonal transition, androgen deficiency, which is the gradual decline of testosterone as men age. The male transition is less abrupt than menopause, but the protective effect fades nonetheless. Add the fact that men smoke at higher rates, which, as we've established, is a primary driver of vascular damage, and you understand why men tend to experience cardiovascular events earlier in life. So the plaque builds slowly. Injury to the vessel wall, cholesterol patching the damage, the lumen, the open channel inside the artery, gradually narrowing year by year. Early stage plaques tend to be stable, firm, dense, covered by a fibrous cap that keeps the contents contained. But the plaque becomes deadly at the exact moment it becomes inflamed. Inflammation makes the plaque soft and unstable. The fibrous cap weakens and then ruptures. Think of an overripe fruit splitting open. The body interprets that rupture as an open wound in the vessel wall, exactly as it would interpret a cut on your finger. It immediately sends platelets and clotting proteins to seal the breach. A thrombus, a blood clot, forms right at the rupture site. If the artery is large, the clot may only partially obstruct it, causing a temporary blockage. If the artery is small, the clot closes it completely. That is your heart attack. That is your stroke. That is exactly what happens at the moment of crisis. And I want to be precise about the word infarction because it is not only a heart event. An ischemic stroke is literally an infarction of the brain tissue dying from lack of blood flow. There are kidney infarctions, intestinal infarctions, but myocardial infarction and cerebral infarction, heart attack, and stroke account for the overwhelming majority of cardiovascular deaths because the heart and brain are the organs least able to tolerate even brief interruptions in their blood supply. Think about the scale of what this means economically and medically. A single coronary stenting procedure for a heart attack, where a doctor threads a catheter into the blocked artery and places a small metal scaffold called a stent to hold it open, costs approximately $2,200. A stroke thrombectomy, surgical removal of a clot from the brain's blood vessels, runs approximately $8,800 per procedure. Operating rooms like the ones I've worked in perform between 10 and 20 of these procedures per day, 7 days a week, 24 hours a day. Every single day. That is the scale of cardiovascular disease in this country. And the vast majority of those patients could have avoided that operating table. Now let's talk about diagnosis. Specifically, how to catch atherosclerosis before it causes an event. The most accessible and informative method is a carotid artery ultrasound, an ultrasound of the neck arteries. Why the neck specifically? Because where arteries branch, and the carotid arteries in the neck have major branch points, blood flow becomes turbulent rather than smooth and laminar. Turbulent flow creates more mechanical stress on the vessel wall, which means plaques form there earlier and more reliably than elsewhere. A doctor places an ultrasound probe against your neck and can directly visualize the vessel wall, measure its thickness, and identify plaques at the earliest stages, before any symptoms have developed at all. This is preventive medicine at its most practical. If a plaque is found, the next step is a comprehensive blood lipid panel, a lipidogram. Not the basic cholesterol number your doctor circles on a standard lab report. A full breakdown. HDL, high-density lipoprotein, which is the protective, so-called good cholesterol that helps remove excess cholesterol from vessel walls. LDL and VLDL, low-density and very low-density lipoproteins, the problematic particles that infiltrate and accumulate within vessel walls. And critically, lipoprotein A, written as Lp(a). This marker is not included in standard lipid panels at most conventional clinics, but it is available at private laboratories. According to the most recent European clinical guidelines, lipoprotein A is now recognized as the single most important predictive risk factor for the progression of atherosclerosis. If your Lp(a) is elevated, that is an unambiguous clinical indication for statin therapy. No debate, no alternatives, statin treatment is indicated. The target of medical therapy is LDL and VLDL, the harmful lipoproteins. What tools do we have? The first is ezetimibe. This drug works by blocking the reabsorption of cholesterol in the intestine. Here's how that works in plain terms. Your liver produces cholesterol, secretes it into bile, and that bile enters the small intestine to help digest dietary fat. Normally, that cholesterol is then reabsorbed back into the bloodstream. Ezetimibe blocks that reabsorption step. The result is a reduction in LDL cholesterol of roughly 50%, about cutting it in half, with a side effect profile that is extremely clean. For patients with early or moderate atherosclerosis who do not yet need aggressive therapy, ezetimibe is often an excellent first choice. It is effective, well tolerated, and works through a completely different mechanism than statins. The second class of drugs is statins, and I'm going to address the fear around statins directly because the misinformation circulating is genuinely dangerous. Yes, there are studies suggesting that long-term use of high-dose statins may be associated with accelerated cognitive decline and may worsen the trajectory of Alzheimer's disease and dementia. That data exists, I am not dismissing it. But here is the clinical reality you need to understand. If you have significant atherosclerotic plaque and you refuse statins, you are very likely not going to live long enough to develop dementia. A heart attack or a stroke will occur first. The statistics are unambiguous on this point. Atherosclerosis and statin therapy represent one of the most extensively studied areas in all of modern evidence-based medicine. There are thousands of large, randomized controlled trials, meaning experiments where people were randomly assigned to take statins or not and followed for years on every individual drug in this class. The evidence base is enormous, and the benefit of statins goes beyond lowering LDL cholesterol. Statins have a direct anti-inflammatory effect on plaque. Remember what we established. It is inflammation inside the plaque that destabilizes it weakens the fibrous cap and causes rupture and thrombosis. Statins reduce that inflammation. A plaque that is no longer inflamed is a stabilized plaque. Its cap remains intact, no rupture occurs, no clot forms, no heart attack happens. This is one of the most important mechanisms in cardiovascular medicine, and it is why statins save lives even in patients whose LDL levels are not dramatically elevated. So why do so many people have bad experiences with statins? Because statins are most commonly prescribed after a vascular event has already occurred. After a heart attack, after a stroke, after an episode of unstable angina. And in that acute setting, doctors prescribe maximum doses immediately to rapidly stabilize inflamed plaque. High-dose statins do carry real side effects: myalgia, muscle aching and soreness, and elevated liver enzymes, AST and ALT, which can cause discomfort in the right upper abdomen. These are the enzymes the liver uses in cellular metabolism, and statin use can raise them. But for most patients, these effects diminish as the body adjusts to the medication. If they persist, a physician can switch to a different statin in the class or reduce the dose. One highly effective strategy is combining a low-dose statin with ezetimibe. Together, they achieve substantial LDL reduction while keeping the statin dose, and therefore the risk of side effects, lower than it would need to be if statin therapy were used alone. You get the LDL lowering from the ezetimibe and the anti-inflammatory plaque stabilizing effect from the statin, with less drug burden overall. The conclusion on statins is this: the side effects are real but manageable. The fear of Alzheimer's as a reason to refuse statins in a patient with significant atherosclerosis is a medical error. Without treatment, that patient will not survive to the age at which dementia typically develops. Now let's talk about the 5 factors that actively accelerate plaque growth, because no medication works well if you are simultaneously fueling the fire. Factor 1. Smoking. There is nothing left to explain here. Tobacco toxins damage vessel walls every single day you smoke. Smoking also causes lung cancer, laryngeal cancer, and a long list of other diseases. If you smoke, stopping is the single most important health intervention available to you. Nothing else comes close in terms of impact per action. Factor 2. High blood sugar and diabetes. Diabetes damages both the small blood vessels, a process called microangiopathy, and the large vessels, macroangiopathy. In diabetics, the kidneys progressively fail due to microvascular damage. Vision deteriorates because the blood vessels in the retina are destroyed, and eventually, large vessel disease causes heart attacks and strokes. Blood sugar control is not optional if you want your cardiovascular system to survive. Factor 3, and based on the latest large-scale research, this may be the most dangerous of all, is hypertension. That is, chronically elevated blood pressure. A study involving more than 60,000 participants directly compared the contributions of diabetes, smoking, and hypertension to atherosclerotic plaque formation. Hypertension won. It was the single most powerful driver of plaque development in that dataset. And here's why this is so insidious. Hypertension is called a silent killer for a reason. Blood pressure of 150/90 or 160/100, many people feel nothing at all at these levels. They say, "That's my normal pressure, I always run a little high." But inside your arteries, persistently elevated pressure is remodeling the vessel wall. The artery stops being elastic and pliable. It becomes stiff, thickened, and brittle, unable to expand and contract normally in response to physical demand. A rigid artery is a damaged artery, and damaged arterial walls are where plaques take hold. Controlling your blood pressure is not a lifestyle suggestion. It is a clinical necessity. Factor 4, excess body weight. And I need to say this clearly because a lot of patients minimize it. Adipose tissue, body fat, is not inert stored fuel. It is an endocrine organ. That is fully established science. Fat tissue produces hormones, pro-inflammatory cytokines. Those are chemical signals that promote inflammation, and drives a process called aromatization, where fat cells convert androgens into estrogens, disrupting the entire hormonal balance of the body. And your heart pays the price directly. For every extra pound of body fat, your heart has to pump blood through additional miles of new capillaries, the tiny vessels that supply that tissue. At a height of 5 feet 7 inches, 170 centimeters, a healthy body weight is roughly 143 to 154 pounds, 65 to 70 kilograms. I have seen patients weighing 309 pounds, 140 kilograms, or 463 pounds, 210 kilograms, whose hearts were working at 3 times the normal load purely due to obesity. Their hearts were literally stretched and enlarged, not from diabetes, not from smoking, not from any other cause, pure mechanical overload. And beyond the cardiac burden, fat tissue sustains chronic, low-grade systemic inflammation throughout the body, and that inflammation reaches your plaques and destabilizes them. Factor 5. Chronic foci of infection and inflammation in the body. This one surprises people every time, but the evidence is solid. Untreated dental cavities, chronic bacterial sinusitis, recurrent bacterial infections, all of these maintain a persistent inflammatory state in your body, and that inflammation is systemic. It reaches your plaques. There was a pivotal research study conducted in the United Kingdom approximately 10 years ago when surgical thrombectomy for stroke, removing clots from brain vessels, was being introduced into widespread clinical practice. The clots extracted from patients' brains were sent for microbiological culture, meaning scientists grew whatever bacteria were living inside those clots. In 60 to 70% of cases, the bacteria cultured from brain clots were oral flora, the exact species that colonize untreated dental cavities. An infected tooth. The bacteria from that tooth seeded the bloodstream, reached a vulnerable plaque in a brain artery, triggered local inflammation, destabilized the plaque, caused a clot to form, and the result was a stroke. Go to the dentist. This is not a cosmetic issue. It is a direct investment in the functioning of your brain. Now, what can you do without any medication to protect your arteries? Movement is the foundation. This is not advice for people who want to lose weight. This is a cardiovascular prescription. Studies consistently show that 10,000 steps per day at a brisk pace, not a leisurely stroll, meaningfully reduces the risk of heart attack and stroke. If time is limited, high-intensity interval training, HIIT, is remarkably effective in a very short session. The structure is simple. 5 minutes of light walking to warm up, then 2 minutes of moderate jogging, then 30 seconds of maximum sprint effort, as fast and hard as you can go. Then 2 minutes of recovery. Repeat the effort cycle. The entire workout takes 10 minutes. Those brief peaks of maximum exertion trigger a full circulatory and lymphatic response that sustained moderate exercise often cannot achieve. If you are completely untrained, start conservatively. 30 seconds of hard effort is still 30 seconds. That is a starting point. Exercise to the point of mild muscle burning also has a documented therapeutic effect on type 2 diabetes. It opens what physiologists call insulin windows, meaning it dramatically increases cellular sensitivity to insulin so that glucose enters cells efficiently. There are rehabilitation programs that have achieved full remission of type 2 diabetes using diet and structured exercise alone, without medication. Temperature therapy, cold showers, cold water immersion, ice baths, causes your vessels to repeatedly constrict and dilate. This is vascular exercise. The vessel wall itself becomes more elastic, the endothelium becomes more responsive, and blood flow improves throughout the body. The current popularity of cold exposure in health and longevity circles is not hype. It is grounded in physiology that cardiovascular medicine has understood for decades. Nutrition. The single most effective dietary change for vascular health is reducing refined carbohydrates, simple sugars, white bread, sweetened drinks, processed pastries, and cakes. These foods cause rapid spikes in blood glucose, which chronically overloads the pancreas and progressively disrupts metabolic function. There is a persistent myth that the brain requires sugar to function. It does require glucose, that is true, but the human body synthesizes glucose perfectly well from protein and fat, through a process called gluconeogenesis. The caloric and metabolic efficiency of fat and protein as fuel sources is substantially higher than that of refined carbohydrates. Look at the indigenous peoples of the Arctic, populations that have historically consumed almost no carbohydrates at all, whose diets consist primarily of fish, whale fat, and animal protein, who expend enormous amounts of energy in extremely cold environments. Their bodies function. When you first cut refined sugar from your diet, you will likely experience withdrawal symptoms, irritability, cravings, difficulty concentrating. That is not a character flaw. That is a genuine physiological dependence. The same neurological reward pathways that respond to addictive substances respond to sugar. The withdrawal is temporary. It passes. Vacuum breathing, also called stomach vacuum exercise, is a simple technique you can perform every morning before eating. No equipment, no gym required. Performed correctly, it activates the deep abdominal muscles, stimulates venous and lymphatic return, improves intestinal motility, and contributes to gradual fat loss around the abdominal organs. And then there is stress, which everyone discusses as a wellness trend, but which has a very concrete physiological mechanism. Chronic stress elevates cortisol and adrenaline, your stress hormones, which push blood pressure up, drive impulsive eating behaviors, fragment sleep, and sustain the same systemic inflammatory state we keep returning to. Acute, short-term stress is something the body is built to handle. What destroys the cardiovascular system is chronic, unresolved stress. Spending years doing work you hate, tolerating situations that should have been changed long ago. These daily conflicts, suppressed and never resolved, create a biological burden that is slower acting than acute trauma, but ultimately more corrosive. Here is something I have noticed consistently in over a decade and a half of clinical work. After 45 to 50 years of age, cardiovascular risk escalates in everyone, and the rate of that escalation is very directly tied to the choices made in the decades before. The younger you are when you start protecting your vessels, the more distance you put between yourself and the operating table. Drop your age in the comments below. I want to see exactly where our viewers are in terms of risk profile. After 50, atherosclerosis tends to accelerate significantly because both male and female hormonal protection has largely declined by that point. Write your age. It will shape the content I build for you going forward. Here is your action plan. Starting from age 40, you need an annual minimum checkup, a full biochemical blood panel with a complete lipidogram, including LDL, VLDL, HDL, and lipoprotein A, a carotid artery ultrasound, optionally an ultrasound of the leg arteries. That is it, a few hours a year, and I will tell you exactly why the threshold is 40 and not 50 or 60. The majority of serious cardiovascular events occur around the age of 50. That is when the hormonal protection has fully declined in both sexes and when the accumulated damage of decades of lifestyle choices reaches a tipping point. The window to intervene is the decade before, not after. I want to tell you about a patient I will never forget. He came in wearing red silk socks. That detail stays with you. Exactly 50 years old. He was driving a car across the country, felt sudden crushing chest pain, and pulled up to our hospital. Massive anterior myocardial infarction, a large heart attack involving the front wall of the heart. We took him straight to the operating room and got to him in time. While I was holding manual compression over the catheter entry point in his groin, applying pressure after the procedure to stop the bleeding at the puncture site, he looked up and asked me, "Doctor, am I actually going to live?" I told him yes, the procedure was done, he was going to be fine. And then he said, "You don't understand. There is a family curse. Every man in my family dies at 50. My grandfather died at 50. My father died at 50. My older brother died at 50. And I am 50 right now." I looked at him and said, "I am officially lifting the family curse." That story is not about superstition. It is about biology. If every man in a family dies at 50 from cardiovascular events, that is not fate. That is a shared risk profile. The same genetics, the same lifestyle patterns, the same failure to intervene at 40. Start your annual checkup at 40, and you will almost certainly pass through that decade without a heart attack. Find a physician, a primary care doctor, or a cardiologist who will follow you consistently year after year. Not a clinic you visit in a crisis. A doctor who has your history, who knows your baseline labs, who can see the trend in your numbers over time. That relationship is worth more than any single test or procedure. The information you just heard will not come up at your regular doctor's visit. The healthcare system is built to treat disease, not to prevent it. And there is no billing code for keeping you well. That is why this channel exists. Subscribe, hit like, and help Dr. Waterling reach 100,000 subscribers. Because the truth about your own body is something you deserve to have.